Sorry. Okay. So we have a jam-packed agenda. We're going to go through a few things. I think you guys will be happy about a lot of them. So our normal COVID epi and updates, some HAN page updates. We're going to go through CRE and then an XDRO overview. Our new pharmacist, well, I guess she's not that new, but new to you, is going to talk about antimicrobial stewardship. And then Sylvia from SIMPAR will provide an opportunity and questions and answers, although as always, you're welcome to ask questions whenever throughout the presentation. And if you haven't already filled out the survey that Angelica put in the chat, please do that now. So in terms of COVID, it's not crazy at the moment, so that's good. Average of less than 1 death a day. Vaccinations are going down, which is not great. But yeah, relatively low number of hospitalizations and deaths, which is good news. In terms of COVID cases at SNFs, we actually are seeing a little bit of an increase. There's usually a lag, so it looks like it goes down abruptly, but that's probably going to come up as you guys continue to report your cases. And right now, about a little less than a half of you have active outbreaks. Variants wise, it's still all Omicron all the time. So no new variants have come on the scene recently that are non-Omicron. This, I think, has changed since our last meeting. So Cook County is now in medium transmission. It has been low, I think, since this map started being around. High transmission is when there's recommendations, like stronger recommendations about new and readmissions testing and things like that. But IDPH and CDPH do support you implementing universal masking again or other mitigation efforts due to the higher hospital admission level. And then in terms of respiratory virus surveillance, there is still some flu going around. There's more in the week ending January 13th than there was in the season to date. But other than that, things are about the same or a little bit less than they were in the past. And here's just a graph about that. Okay, sorry, I know I'm going fast, but I'm trying to make sure we have time for our special guests. So no changes in required routine staff testing. Again, as always, if you have a staff member who's symptomatic, had an exposure to a case, or your facility's an outbreak and you're performing broad-based testing that impacts that staff member. So for example, you're having an outbreak on the 4th floor and the staff member works on the 4th floor, then you should test them. And resident, same thing. So as I mentioned earlier, so new and readmissions, regardless of vaccination status, if we are in high hospital admission level, which again, right now we're in medium, it's in a facility discretion, but it is something you might want to consider because then the people in the community, there's a higher rate and higher risk of COVID, so you don't want them to bring that into your building. This is the part I think you'll be excited about. So as you know, those of you who report cases, it takes a very long time for you to report each case because we asked you for every vaccination they got and what city it was in and what date and what type. So we have really streamlined this form, taken away a ton of questions. So hopefully it's much faster for you. Reminder that this form should be used for any SNF case. And then if you have an assisted living, if you're a CCRC that has an assisted living that's next to or same building as your SNF, and especially if you're sharing staff or a lobby, we'd also like those cases to be included. However, if there's any assisted living facilities on the call or supportive living facilities that have no SNF portion to their building, they actually report using a different form. And I have that linked there. Nisreen would be their IP contact. So again, if you're in a CCRC that includes a SNF, you report this form. And if you're in a AL, SL, or CCRC with no SNF component, then you report in another form. So I just want to go through some of the changes. This is what it looked like before. So if you said someone was symptomatic, we would ask you every single symptom. We'd ask you if they were in the ER. We'd ask them if they went to the ICU. And now this is all it is, that section. So did they have signs and symptoms? If yes, nothing else besides the first or the date of onset. Were they admitted? Yes. And then give us the information about that hospital. If you say no to those, then it's just, did they have symptoms? Were they admitted to a hospital? So hopefully that saves you some time. Laboratory information, we asked you a lot, like what lab conducted testing, what type of tests, were they tested? And now the new one is just what type of test, the date of the test, and had they had COVID in the last 90 days. So hopefully that makes it easier as well. The part that I think you will be most excited about is this table, especially as there's tons of doses now. You have to fill out, or we asked you to fill out for every dose, all of this information. And now we just say, are they up to date or not? So again, hopefully that saves you tons of time, especially those of you in an outbreak who have to batch enter a bunch of cases. In terms of rapid tests, so I'm not sure if IDPH reached out to you, but some of you had, there was an ordering period where you could order rapid tests that they had available. And um, that ordering period has closed. IDPH did let us know who ordered tests, and we need to come up with a storage and distribution plan on our end, because I think it was about, of all of you, 17,000 tests were ordered, and we don't really have the space for that here. So we're working on that distribution plan. We will let you know. But again, if you already requested them, you should be getting them at some point in the near future. If you did not request them, that period for request has closed. And I do think they might expire relatively soon. So if and when you do get them, just make sure you're looking at the expiration dates of those tests as compared to the other tests you have on site, and use whichever ones are going to expire first. But do remember that there's often extensions on expiration dates. So you can go to websites of whatever that test is, and it'll tell you, put in the expiration date that's listed on the box, and it'll tell you what the new expiration date is. And then I'm going to pass it over to Stephanie to talk about some exciting updates on our HAN page.
Hey, can you hear me?
Yeah, we can hear you.
So just going over just a few changes we had. This first page just talks about how to find our HAN page for long-term care facilities. We usually link it on our follow-up emails at the very end, but you can also just type in chicagohan.org/LTCF, and that'll take you directly to the long-term section. Next slide. And this is just kind of showing you, for the most part, we are planning to update the page. Currently, this is kind of the setup. It's still mostly all the tabs are related to COVID-19. So in that box, that's all going to be focused on COVID-19 resources. And then that other tab below it, other diseases, we've put in like the influenza, scabies, and now we've also added resources for gastroenteritis and Legionella on there. And then we also have a tab for additional resources, and that one kind of links more of the transmission-based precaution information. Next slide, please. So for gastroenteritis, we've kind of just focused on the stuff that we see mostly in the long term. So we put in norovirus guidance, C. diff guidance. We've also included an outbreak line list template. So if you are experiencing outbreak, you can download that, and it'll ask for like last name, first name, signs and symptoms, were they tested, and that's what you can also use to report back to us. And then for Legionella, it has the CDC guidance link on there, so you can click on that so you can learn more about Legionella. But it also includes the water management program toolkit from CDC, and that one kind of walks you through what is Legionella, is your facility at risk, what things you should implement. And then the other one is the Legionella environment assessment form. This is more kind of like a surveillance kind of thing, where when we go in, things that we look for. So it's a good document so that you can see what we look for when we go into a facility, when we're looking for Legionella, or like a risk assessment for Legionella. And that's it for new updates.
Thanks, Stephanie. Okay, now I'm going to pass it over to Allie and Cece to go through a CRE 101.
Hi, good afternoon. I'm Cece. Allie and I are just going to go through some basics of CREs. You can go to the next slide. Yep. Okay, so these are emerging carbapenem-resistant organisms. The ones we're going to be focusing specifically on today are the carbapenem-resistant Enterobacterales. These are all gram-negative organisms that are emerging of concern. They all follow similar processes when it comes to mechanisms, but the one I'm talking about in the basics today is the CREs. So, yep. So Enterobacterales is actually an order of bacteria. They are gram-negative rod-shaped bacteria that test positive for resistance to at least one carbapenem antibiotic. Some common ones are, of course, Klebsiella pneumoniae, E. coli, Salmonella, and Shigella. And then, Liz, if you can click again. The carbapenems, one of them, one of the categories of the beta-lactam antibiotics is carbapenems. Carbapenems are extremely important. They're one of our last lines for very sick patients. In killing these bacteria. They are important to kind of disrupt the cell wall and membranes of these bacteria to kill them off. We've been using them for about 20 years. So having resistance occur in these to these particular drugs is super, super important for public health to tackle and kind of take care of. You can continue. So how these CRE become resistant to carbapenems, there are 3 different ways. One of them is just through chromosomal mutation. Something happens within the bacteria to limit or kick out the carbapenem antibiotic from the bacterial cell. Other ways is they acquire a gene through horizontal gene transfer. These are the non-carbapenemase producing mechanisms. And then the third one is obviously the carbapenemase producing mechanisms. So this is a great picture provided by the CDC on what these mechanisms are. The 2 on the left are chromosomal mutation and acquired gene related. The one we're really focusing on and emphasizing in this presentation is the carbapenemase producing mechanism for resistance. What this is you can see within this bacterial cell, the little orange dots. What these do, these enzymes are able to inactivate the antibiotic within the cell, and then, the bacteria has a way of protecting itself. So when a CRE uses carbapenemase production for resistance, we call these carbapenemase producing CRE. So they all are CRE. It's just that this is a subset of CREs because this is the known mechanism that this particular bug is using to resist carbapenem antibiotics. Carbapenemase enzymes, what they do is they inactivate those carbapenems and other beta-lactam antibiotics. These include like penicillins and cephalosporins. But yeah, this is what we're talking about when we say something like CRE is just a subset of CRE. They're all CRE. We're just talking about a specific mechanism involved. And then the carbapenemases. So these are our common ones with the CREs. We'll get into these little characters that I've assigned to these carbapenemases in the next slide. So in this example, we're going to kind of walk through what you will see are caves, and these caves is a patient or a resident that is colonized or infected with a CPCRE. And the monsters you're going to see are those little carbapenemases. So what can happen is, so these are 2 different patients, and they're infected with both Klebsiella pneumoniae, let's say. They can have different mechanisms of resistant to our antibiotics. So this one in this example has NDM, and this one in this example is KPC. And then you can also have what happens is, like, say this is E. coli, and this is an oxytosa organism, but they have the same mechanism of resistance. What we don't want to have happen, and what is most important in cohorting with these CREs, is that we don't want organisms that have different mechanisms to be in the same room, because what can happen is these bacteria are able to share these forms of resistance, and we do not want to start creating superbugs. So yeah, this person has acquired all of these bugs, and that's a really hard place to be in because that makes it, obviously very hard to treat. And then I'm going to pass it to Allie.
Yes, thanks, Cece. So now we are going to talk about how CRE spreads and what we can do at our facilities to prevent transmission as much as possible. So in 2019, the CDC estimated antibiotic-resistant bacteria and fungi caused almost 3 million infections and 3,000 deaths. And many of these infections are occurring in individuals who are already sick. which aligns with these risk factors. So residents at long-term care facilities are already at elevated risk for CRE. And then within this large group of residents, there are additional tiers of risk to consider. So residents who are receiving complex medical care, for like those of us who have residents on ventilators, as well as residents with indwelling devices, those who have taken certain antibiotics, like those carbapenems that Cece was talking about, and then residents who require assistance with tasks of daily living, such as bathing, toileting, and dressing, are also at higher risk. And then there are 4 main ways that CRE spreads. We have direct contact, which is what we think of with how a lot of bacteria spread. And then we move into hands of healthcare workers. So like many other types of bacteria, these CREs can spread on the hands of healthcare workers as they move from resident to resident or room to room within your facility. And then there's contaminated environmental surfaces. So this includes some of the high touch surfaces we think of high priority cleaning during EVS, from an EVS perspective, like bed railings and TV remotes. But CRE can also contaminate wastewater plumbing and spread via splashes from sink drains and toilets. So we really want to be considering the entire environment. And then lastly, they can spread via shared medical devices. So this falls under the category of like indirect contact. And they can spread with something like blood pressure cuffs or portable x-ray machines that you would be using on multiple residents. So we want to prevent this spread. And one of the first steps your facility can take, whether you have known cases of CRE or not, is to enroll in the XDRO system and check each time you have a new admit whether they are already colonized. So this system will let you know if a new resident has ever tested positive for CRE as well as some other NDROs. And I know there's more information coming on XDRO later in this roundtable, so I'm not going to spend too much time on it. But this will help us alert IPs and at your facility who needs to be put on transmission-based precautions. Then, of course, we want to emphasize proper precautions and PPEs, which with CRE is going to focus on gown and gloves as well as hand hygiene. And we know when residents have CRE and are placed on enhanced barrier precautions, we're going to be using gown and gloves a lot. So a reminder that hand hygiene will be performed every time you remove those gloves. If you're moving between patients in the same room, you'll want to perform hand hygiene when you change gloves. If you're moving between rooms, we want to practice good hand hygiene as well. And finally, cleaning and disinfecting the patient environment and medical equipment. This is something you'll work with your EVS staff to make sure is being accomplished to create a safe environment to prevent the spread. And with CRE, the main type of transmission-based precautions we'll be working with is enhanced barrier precautions. So hopefully these images on the left, or at least the orange color of the box, look familiar. They should remind you of the door signs from CDC that we used, or we recommend using on the doors of residents who are using enhanced barrier precautions. And once a resident tests positive, we do consider them positive for our sakes forever, um, which is why we recommend EBP, because it does not limit the freedoms of residents to move around the facility, which is their home in this case. And just a reminder that EBP is focusing on high contact resident care activities. So staff, gown and glove is not required if someone's just bringing in, a bottle of water to place on a nightstand. It's really focusing on these certain activities where staff members will be in close proximity to the resident or the resident care environment. And lastly, I just wanted to touch on what to expect. If your facility already has known cases of CRE, this might be something you've experienced. If someone at your facility were to develop CRE, what you can expect is a reach out from CDPH or our team. We're going to talk about 3 main areas. We're going to recommend enhanced barrier precautions, whether that resident is colonized or infected. We're going to talk about initiating EBP. We're also going to talk about private rooms and cohorting. When possible, we recommend new cases are placed in individual rooms. We know with facilities who have multiple residents who are colonized or infected with different organisms, cohorting may be necessary, which is something that our team at CDPH is happy to talk through and walk you through and develop a plan to prevent transmission at your facility. And the last branch of this approach is additional testing. So CDPH will reach out if we want to complete additional testing, which is basically or primarily roommate testing. And this testing does not always occur, so you don't need to panic if we haven't done it or you haven't heard from us about additional testing. And it's really decided based on the mechanism. So those carbophenamases that Cece was talking about, for example, we're probably not going to pursue roommate testing if it is a KPC of CRE, but some of the other mechanisms will draw our attention to roommate testing. And that is what we have for you on CRE.
And good afternoon, everybody. Can you hear me okay?
Yep, we can hear you.
All right, great. So welcome to today's presentation on XDRO, on the XDRO registry. Just a heads up, I will be reading a few of the slides, but I promise to keep it interesting. Next slide, please. So what is XDRO and why do facilities need it? XDRO is an Illinois registry implemented in 2013, designed to promote information sharing among healthcare providers. XDO provides standardized reporting of CRE carriers across healthcare facilities throughout the state. The registry receives CRE reports and centrally stores the information. Facilities with access to the registry can then query or search the site for patient history. XDRO is a much needed resource because it allows facilities to mitigate the spread of XDROs, to cohort patients properly, and also to stay informed on patient status, whether they're coming in and out of the hospital and back and forth from the facility. It allows you to stay informed on their status. Next slide, please. So things that should make you say, the emergence of XDROs is a major health problem because few or no effective antimicrobial drugs are available to treat infections caused by these bacteria. Failure to control the spread of antimicrobial drug-resistant bacteria hinders medical care at a growing number of facilities by creating hazardous opportunities for untreatable infections. The CDC recommends a detect and protect strategy. Detect CRE patients through systematic surveillance and protect patients by preventing transmission of CRE through application of appropriate infection control precautions when they enter the facility. To improve the effectiveness of the detect and protect strategy, information needs to be shared routinely among facilities. So here on this slide, the problem with XDROs and their spread is described as a major public health problem, and solutions to that problem are provided, which include systematic surveillance and also widespread communication among facilities. Next slide, please. This slide is about 8 years old. It's from 2015, but it shows the different approaches that were used in the past to combat XDRO infections, which are still valid today. So with the first approach, the common approach is when facilities have experimented on their own and tried what works. I mean, they experiment on what may work and then try it. With the second one, independent methods and practices are used among facilities. And then that third approach, the coordinated approach, is where we are headed, where we're aiming to go in the city of Chicago. That's the coordinated efforts used statewide through the XDRO registry. Next slide, please. And this is where we are today in Chicago. The blue slice represents facilities that have access. The orange slice represents facilities that have sat through my spiel, completed their application and are waiting for approval from IDPH. The gray portion represents 74 out of the 106 facilities that are avoiding my calls and do not have access. No shade though, really. We are seriously just here to help you. Next slide, please. The good news is that the XDRO registry is paired with the Illinois Disease Surveillance System, which is formally known as INETS, which means if you have IDES, I believe that's what it's being called now, you have access to XDRO. But don't worry, if you don't have either, this presentation is going to walk you through the process. Next slide, please. Access to the registry is granted through IDPH, but I'm here to help. I can walk you through the application over the phone, which takes about 15 minutes. If there's a large group of you, it should still pretty much take the same amount of time, maybe 20 minutes at the most. And on that call, we'll visit the portal to register. Once on the page, you'll register for a portal account, complete the required fields, and don't forget to write your password down in a secure location. You're going to need it once your once your account is approved. Next slide, please. So if you're an IP or a nurse or someone who's going to use XDRO on a daily basis, you'll get a general account since you'll be doing the data entry. If you are corporate and management personnel, are preferred PRA account holders, and all applicants except PRAs should complete the application as shown on this page. The purpose for registration is going to be a little bit different for anyone who is completing a PRA account. And by all means, if you're going to be filling out for a general account, you can use the sentence in that red box right there. Make sure you just update it with your pertinent information. But use this sentence when completing that application and the purpose for registration. Next slide, please. All right. IDPH requires facilities to have, just a side note before I move on to this slide, PRA accounts are required for each facility, which will be described as we go on. So now this slide, IDPH requires facilities to have PRA accounts as mentioned. The application is the same. The only difference is the information put into the purpose for registration. So for those who are needing a PRA account, you're simply going to put in establish PRA, which is circled right here in red. That's the only difference. Next slide, please. The PRA is an individual that authorizes accounts and also closes accounts. So you'll need to find out who your PRA is at your facility. If you do have one, get their name and email address. You're going to need it to complete your application. If you do not have a PRA established, but if there is no PRA established at your facility, there's a strong chance that your application could get denied. So basically, the bottom line is you really need to have a PRA in place for a better outcome. So moving back to the application, at the very bottom of the application where it says Portal Registration Authority, you're going to click that blue hyperlink to continue on and complete the application. Next slide, please. So after clicking that blue hyperlink, a pop-up menu is going to appear. If your organization does not have a PRA, you can enter IDPH as your search for your organization. And again, I have will on here, IDPH will act, but that is a strong may. They may act as a temporary PRA to establish your account. And also, if there's anyone from IDPH in this meeting and would like to chime in, provide any type of clarifications, explanations, updates, any additional information at all, feel free to do so after this presentation. Next slide, please. When the IDPH option populates, you're going to select the third option from the top, which is that DPH security. Your selection is going to then appear at the bottom of the registration page. Once you close this box, that email address is going to appear right next to that blue hyperlink where we clicked to select the portal registration authority. So once you see this email address, once it pops back to your registration page, your application is pretty much complete. I do stress again that you save that password and go over your application. Make sure all your I's are dotted, all your T's are crossed, and then you can hit submit. Next slide, please. Let me see where I am. All right. So the PRA agreement. If you are signing up as a PRA, you'll need to submit the PRA agreement with your application. During our call, I'll send it to you and I'll need you to complete it, sign it, and date it. And then you're going to return it to me via email along with your confirmation page. And also, when completing this page, make sure you complete the entire section. No scribble scrabble. Please print legibly. Make sure your signature is intact. Just don't leave any blanks. Next slide, please. If your facility has a PRA, again, you want to make sure that you get their name and email address. At the bottom where that blue hyperlink is, again, you're going to click on that hyperlink to search for your PRA. So it's basically the same steps, only you're going to use the name of your PRA and not IDPH. Their name is going to populate, you're going to select it, and then it's going to appear back on the bottom of that registration page where we hit that portal registration authority. And like I said again, proofread your application, make sure you write that password down, and then hit submit. Next slide, please. As you can see, that confirmation page is very important. So when this page populates, you're going to print it, sign it, and date it. Make sure all of the appropriate signatures are on this page, which is you. You're going to sign as the applicant. You're going to have your supervisor sign. And if you have a PRA, you're going to have that PRA sign and date as well. And remember, if you are not signing up as a PRA, you're just going to send me one page, which is the confirmation page, signed and dated, all the appropriate signatures. If you are signing up for a PRA, you're going to send me 2 pages, the confirmation page along with your PRA agreement completed, accurately signed and dated. Next slide, please. Next, your documents will be sent to IDPH for processing, and you will receive a direct response from them regarding your application status. If you receive an email saying anything other than your account has been approved, contact me immediately and forward me that email. We'll work together to solve the problem and get your account established. Next slide, please. And these are some great resources for you if you currently have XDRO and need pointers on setting up alerts or anything else. The training videos, that second one, the training videos will show you how, and they have some good information in there. Next slide, please. And this slide provides tips on how to prevent transmission within your facility. So when you get these slides, just make sure you take a gander at this. It's a good idea to read through some of those resources. Next slide, please. And this beautiful person right here is me. Yay! So if you have any questions or concerns, Feel free to reach out to me in any method, whether it's email, voicemail. Feel free to reach out to me anytime. I am seriously here to help. Phone calls, everything. Just contact me any manner, and I look forward to hearing from you all. Everybody have a great day. I'm going to pass it over or back to Liz.
Thanks. And I think I'm passing it to Star.
Okay.
Yes, thank you. So good afternoon, everyone. My name is Star Cervantes. I am the Antimicrobial Stewardship Lead for CDPH, and today we're going to be going over the basics in stewardship in nursing homes. So just some statistics, there are about 4.1 million Americans that are admitted or reside in nursing homes during a year. This has been shown similar to, we have seen similar findings in hospitals where studies have shown that 40 to 75% of antibiotics prescribed in nursing homes may be unnecessary or inappropriate. Additionally, the CDC has reported a cost estimate of antibiotics in nursing home ranging from $38 to $137 million per year. Residents in nursing homes with higher antibiotic use have been shown to have an increased risk of antibiotics-related harm. There's also an increased risk for residents who do not receive antibiotics through indirect antibiotic-related harms from the spread of resistant bacteria or C. diff germs from other patients. Next. There's a lot of different factors that should be included in prescribing decisions when prescribing any antimicrobials. I've included some examples of that here, but things to consider would be like patient attitudes, if they're willing to have an antibiotic, if they're voicing concerns or require more education about that specific antibiotic that you're trying to prescribe, or if they have questions on side effects. Those are things that we should consider when prescribing and talking to patients. Next. So healthcare facilities are all interconnected, so the nursing homes play a huge role in decreasing the regional spread of multi-drug resistant organisms in all healthcare settings, since they are interconnected and with patient care transfers. Next, we'll talk about the CMS requirements. So as part of the revised requirements for participation in CMS, they required all long-term care facilities to have an antibiotic stewardship program, and this was enforced in 2017. So next we'll go over the CDC core elements in stewardship in nursing homes. So we can talk about the next slide. And then one more slide. So we'll go through all the stewardship core elements that the CDC has proposed. So the first one being leadership support. So the CDC recommends facilities demonstrate leadership support for antibiotic stewardship. This includes like having a written statement of leadership support to improve antibiotic use, having stewardship duties included in either your medical director, clinical nurse leads, and consultant pharmacist job descriptions. This also can include leadership monitoring adherence to antibiotic stewardship policies, and additionally, antibiotic use and resistant data that are reported in quality assessment and assurance meetings, so those QAA meetings. Next, we'll be talking about the second core element, which is accountability. So the CDC recommends facilities have identified at least one leader who is accountable for antimicrobial stewardship activities. This will include the medical director, who will set standards for antibiotic prescribing practices for all clinical providers credentialed to deliver care in nursing homes and be accountable for overseeing adherence. Additionally, the director of nursing or the DON can set practice standards for assessing, monitoring, and communicating changes in a resident's condition by frontline nursing staff. So nurses and nurses' aides play a huge role in decision making for starting antibiotics in nursing homes. The consultant pharmacist or facility pharmacist can support antibiotic stewardship oversight through quality assurance activities such as medication review and reporting the antibiotic use data. Also, infection prevention coordinators have key expertise in data to inform strategies to improve antibiotic use. This includes tracking of antibiotic starts, monitoring adherence to evidence-based published criteria during an evaluation and management of treated infections. And they're able to understand which infections are being caused by resistant organisms. If your facility has a consultant laboratory, this can be super beneficial as they can provide reports and services to support antibiotic stewardship activities. So this would include supporting antibiotic stewardship by developing a process for alerting the facility if a certain antibiotic resistant organism is identified. So there's different tests that they can provide and use to detect infectious pathogens that can be used to develop a summary report of antibiotic susceptibility patterns from organisms isolated in different cultures. And lastly, state and local health departments, nursing homes benefit from educational support and resources of antibiotic stewardship and infection prevention, which are provided by our HAI, our Healthcare Associated Infection Prevention Program teams at state and local health departments. Next, we'll go over the third core element, which is drug expertise. So the CDC recommends facilities have access to individuals with antibiotic stewardship expertise. So like we talked about before, this can include your consultant pharmacist that has specific training in antibiotic stewardship. Additionally, having a antibiotic stewardship team at a partnering hospital. And lastly, having an external infectious disease antibiotic stewardship consultant group. So receiving support from infectious disease consultants and consultant pharmacists with training can help nursing homes reduce antibiotic use and experience lower rates of C. difficile tests that have been shown in studies. Next, we'll be talking about action, which is core element number 4. CDC recommends facilities have policies to improve antibiotic prescribing use. So this includes having all antibiotic orders have a dose, frequency, duration, and indication, the use of facility-specific algorithms to assess residents for suspected infections and requesting diagnostic tests for specific infections, also use of facility-specific treatment recommendations for infections, and antibiotics are being reviewed before being added to medication formularies if one exists. Next, we'll talk more deeply about some of the implementation practices to improve antibiotic use. So for example, standard assessment and communication tools, so SBARs, if you guys have heard of those. So implementing structured communication tools to guide nursing physician interactions. So this includes our SBAR, which is a situation background assessment recommendation protocol, can improve the quality of communication and subsequent management processes when an infection is suspected. Additionally, having antibiotic use information and communicated or received on transfers. So using those facility information tools that we talked about in the previous presentation can be used and should be include key pieces of clinical history, including like symptoms, complaints, physical exams, and other relevant information when patients are being transferred or received. Reports summarizing antibiotic susceptibility patterns. So this includes working with your consultant laboratories to create facility-specific summary of antibiotic susceptibility patterns, also known as our antibiograms, from organisms commonly associated in microbiology cultures. Reviewing and antibiotics and doing timeouts for specific antibiotic orders. So nursing homes should have a process in place for a review of antibiotics by the clinical team, usually 2 to 3 days after antibiotics are initiated. And this will help answer very key questions like, does this resident have a bacterial infection and will they respond to antibiotics? If so, does the resident, are they on the most appropriate antibiotic dose and route of administration? And can this spectrum of antibiotic be narrowed or the duration be shortened, also known as de-escalation? Lastly, reducing prolonged antibiotic treatment courses for common infections. So there's been a large study of antibiotic prescribing practices in nursing home that demonstrated that over 50% of antibiotic treatment courses extended beyond a week with no correlation with resident characteristics or type of infection being treated. Given the growing body of evidence that short courses of antibiotics are effective for common infections, interventions that are designed to decrease antibiotic duration among nursing home residents may reduce the complications and adverse events associated with antibiotic exposure. Next, we'll see some examples of an SBAR form. So this is available for as like a template, and I'm sure most of you are familiar with these. Next, I don't know why these black boxes are there, but this is the CDC interfacility infection control transfer form that we had talked about earlier. So this is directly from the CDC. This can be used when transferring patients. Next, we'll talk about, or we'll see an antibiogram template. So this is directly from the AHRQ website, which we'll talk about in a couple slides, and how an antibiogram should look if we have enough reported isolates. This can be something that is done at a facility level. Next slide. Thank you. So additionally for action, the CDC recommends facilities have a consultant pharmacist to support stewardship activities, and this person will be responsible for reviewing antibiotic appropriateness based on the agent selected, the regimen, the duration, and therapy and indication. This person will also establish standards for clinical laboratory monitoring for antibiotic-associated adverse events and also reviews microbiology cultures data to assess and guide antibiotic selection. So integrating your dispensing or consultant pharmacist into the clinical care team is as a key partner in supporting stewardship in nursing homes is very valuable. Pharmacists can provide assistance in assuring antibiotics are ordered appropriately, that culture data is being reviewed. They are developing antibiotic monitoring and infection management guidance in collaboration with nursing and other clinical leaders. Next. More on to action. So they also recommend the facility has infection-specific interventions to improve antibiotic use. So the CDC recommends that we're identifying clinical situations which may be driving inappropriate courses of antibiotics, such as asymptomatic bacteriuria or urinary tract infection prophylaxis, and implement specific interventions to improve use. So antibiotic use for the treatment of asymptomatic bacteriuria in nursing home residents does not confer any long-term benefits in prevention or preventing symptomatic urinary tract infections or improving mortality, and may actually increase the incidence of adverse drug events and result in subsequent infections with antibiotic-resistant pathogens. There's been surveys of antibiotic use that have shown that UTI prophylaxis accounts for a significant portion of antibiotic prescriptions. Optimizing management of nursing home associated pneumonia, implementation of algorithms for diagnosis and management of nursing home associated pneumonia may be valuable in helping guide decision makings about which antibiotics to use and if they need further hospital transfers. And the last one, optimizing use of superficial cultures for management of chronic wounds. Although obtaining specimens for wound culture can guide help antimicrobial treatment, reliance on just superficial swab cultures alone may drive inappropriate or unnecessary antibiotic usage. Next, we'll talk about the core element number 5. So facilities monitoring or tracking one or more measures of antibiotic use. So the first one being process measures, which is tracking how and why antibiotics are being prescribed. The second one being antibiotic use measures, tracking how often and how many antibiotics are prescribed. And the last one is antibiotic outcome measures, tracking in adverse outcomes and costs from antibiotics. Next, usually core element 6 and 7 or 5 and 6 are usually together. So tracking and reporting. So it's the exact what we're tracking is what we want to be reporting. So sharing those facility specific reports on the use of antibiotics and the outcomes with clinical providers and nursing staff. So an example would be measures of antibiotic usage at the facility that we talked about that we would be tracking, looking at those different outcomes related to antibiotic use. So like C. diff rates, reporting of facility antibiotic susceptibility patterns, and those would be our antibiograms, and then personalizing feedback on antibiotic prescribing practices that would be only shared with individual providers. So the next and last core element is education. So the CDC recommends facilities provide educational resources not only just to the staff, but to patients on antibiotic resistance and antibiotic use. So there's a variety of mechanisms for disseminating antibiotic education to nursing home staff. This includes like flyers, pocket guides, newsletters, electronic communications. However, they have seen that interactive academic detailing, so this includes face-to-face interactive workshops, has had the strongest evidence for improving medication prescribing practices. There's been some studies also in nursing homes that they have seen improvements by incorporating both education and feedback to providers. So one nursing home antibiotic stewardship intervention demonstrated a sustained reduction in antibiotic use for 2 years after the intervention by linking education with feedback on physician prescribing practices. There was another study also that showed a 64% reduction in inappropriate antibiotic use. So those are prescriptions that do not adhere to the guidelines by providing feedback on individual physician prescribing practices and adherence to the guidelines over 12 months. So next slide, this is an example of the CDC patient education flyers that are available to download to have at your sites if they have any questions. These are super user-friendly and patient-friendly. Next, we have some stewardship training for nursing homes. So this is the first one is the AHRQ toolkit, which I talked about earlier, where we got that antibiogram template. It's a really great toolkit to have, and they're all free. We also have CMS and the National Nursing Home Quality Improvement Campaign, who also provides nursing home training sessions on antimicrobial stewardship and checklist. Next, I wanted to show you briefly the AHRQ minimum criteria tool for antibiotics. So this is a really great tool if you're having a resident who is suspected of having an infection. You can start off with the potential infection that of concern and then break it down into different symptoms. And then it will tell you if the minimum criteria is not met. It will give a list of recommendations for comfort, monitoring, and additional testing that may be required to rule out any other infection. Next, we have additional stewardship trainings. We have the Nebraska tools and templates for long-term care, Rochester Nursing Home antimicrobial stewardship references as well, and the Minnesota Health Department also has a great toolkit for long-term care facilities. Next, we have our own Chicago Han website that I'm sure you guys are all very familiar with, but we actually have a stewardship page as well, which I included the link at the bottom. We have healthcare-specific antimicrobial stewardship resources for not just nursing homes, but hospitals, outpatient clinics, and patients. We also have educational training courses links that we talked about in the previous slides, treatment guidelines, publications, other helpful links, and contact information as well. And then the next slide just shows a snippet of what our antimicrobial stewardship page looks like. And you can find those long-term care or nursing home resources under the antimicrobial stewardship resources tabs. And we have them linked there for you as well. And I think that is all I have. And if you guys have any questions, I can provide my contact information, but it's also available on the Han as well. Thanks.
Thank you. Okay, I think our last topic is from Sylvia, so I'll pass it over to her.
Hi,
Okay.
everyone. My name is Sylvia Jasnik, and I'm a nurse here at SIMPAR. If anything that Star just went over seemed a little unfamiliar or maybe kind of in the back of your mind as something that you're looking to improve at your facility, please, please, please do join us at Weiss Memorial Hospital on February 28th. So that's coming up in almost exactly a month for a full day of antibiotic stewardship topics. This is really, really cool because it gets us all in the room together and we get to learn from each other as well as subject matter experts on how to actually implement these topics in your facility. There's amazing resources out there that already wrote all of the ways that you can do it, but how do you actually get those resources from the internet, from the papers that they're on, and into practice at your facility? So please join us on February 28th to talk specifically about antibiotic timeouts and management of common infections in LTCs. And then again, same place, same time on March 27th, we're going to go and explore anabiograms on a deep level and go over all of the quality measures that you can keep tracking, start tracking, and use to determine your progress on antibiotic stewardship. Lunch is provided, definitely. There's a whole bunch of activities. So bring a laptop or a smartphone if you're able so you can participate fully. But it's definitely going to be a really cool day to explore all of the topics that we just covered. If you want to register, go ahead and scan this QR code in the middle. It's going to take you to asp.simpar.com. So you can register for any of the in-person workshops there. There's also other locations if this happens not to be your best location for you, or reach us directly at asp@simpar.com to see if there's any other way that we can help you in maintaining, starting, perfecting antibiotic stewardship at your facility.
Thank you. Okay, there's been some questions in the chat, so I'll just go over some of those quickly. And then if anyone else has questions, throw them in there and then we will wrap up. So Amy from Alden was asking, what if there's already a portal account, but no INEDs or XDRO access, and is the registration process the same? And near the end of the chat, Hira put in that FAQ. So if you do already have a portal account, so you have the portal, but you don't have those two applications on there, they don't want you to do it in a totally new registration form. You should talk to your PRA, who then would contact the IDPH contact and ask for that additional application access. So for INEDs and XDRO. And let me see the other ones. My chat's being kind of weird on my computer versus my phone, because I did see someone ask about the slides, but I don't see it in here. But anyways, the answer to that one is that slides are posted on our website a day or two after we're done with these presentations. They are a little difficult to find, but for the Chicago-based SNFs, we do those routine follow-up calls with you about once a month, and then we do additional calls if you have an outbreak. We send those long follow-up emails after those calls, and every one of those near the end will have the link to the most recent IDPH webinar, the Friday webinars, and the most recent this webinar, basically the most recent one of these. So any emails that will be going out next week will have, as long as our web team posts to our website on time, next week's emails will have this particular roundtable slides and recording. If you are not affiliated with a SNF, so anyone from IDPH, or if there's any out of jurisdictions facilities, you just email us and we can get those slides to you. And then, okay, it sounds like Tasa and Amy are going to connect and then start putting her contact info. And I think that is it. Unless if anyone else has any questions, feel free to unmute or throw it in the chat. Otherwise, enjoy your 4 minutes we're giving back to you. Oh, and then last thing I was going to say is feel free to either email or throw in the chat or